So we've known each other for a long time, so we're going to be very interactive. So we asked, hey, just how many of you invest in healthcare? Is that like a widespread thing? Okay. How many of you go to a doctor and care about healthcare? By the way, how many of you have a concierge doctor? Because you just want only about half. I'm surprised. It's probably. I hope the others actually have a doctor they can see it.
Any recommendations for my mom? I'd appreciate it. Definitely shopping for
Oak Street.
So I guess this is the way we're going to roll, Lyle. All right, let's go. So how did we actually originally meet?
You know how we met.
I think that's how we met, but is that the rendition?
Yes, my office. You buy me lunch.
All right. So I was a pharmaceutical rep, and I called on Lyle, and I thought I may have met you when you were a resident at Northwestern.
You might have been. You were probably repping then, drug rep then.
Yeah, that's when it was.
It was in the hospital, I bet.
And then I started dating this girl, and
you met me before you met her.
I think so.
Okay.
I think so. And anyways, there's our little life with Lyle and Dan. And so for the last 30.
Wait, just so you know, the girl was my cousin. So it wasn't like
that makes it a little more relevant. But over the last 35 years, we've both been in healthcare. Kind of grew up together in this space. And, Lyle, I thought it might make sense just to start with your background in just a second. But just to set the context beyond what Lyle just shared, like, hey, we all see doctors and we all need them. Why is this such an interesting conversation? I'll just take a shot at why it's so important. So from an investor or a personal perspective, however you want to look at it, the U.S. Economy, right? So if you look at GDP, the number one sector is healthcare, right? So it's 20% of GDP and growing. So $5 trillion a year are spent on healthcare. There you go. So that's the setup. Of that $5 trillion, about $2.5 trillion roughly flows through healthcare providers. So that could be hospitals, that could be doctors' offices, right, on the provider side. The other 50% is all affected by the first 50%, okay? And Lyle and I have been spending all of our time for the last 35 years on the provider side. So just give a little bit of your background, how you grew up and what you're doing now, and then I'll do the same.
So I'm a physician, primary care physician. I spent 20 plus years at Northwestern Medicine in Chicago, helping build what became the largest primary care medical group in the city. So Northwestern's medical group. And along the way, I started out like as an undergrad as an engineer, but I knew I wanted to get into healthcare. I wanted to be a doctor, but I wanted to apply technology into healthcare because I'm like most engineers. I just constantly see how can we do this easier, faster, better, et cetera. And so in the 90s, as I became a doctor, I was also became a health system executive. I was a medical director of technology and eventually of innovation for Northwestern primary care group and eventually for the whole system. And along the way, I got involved, hapstance in a variety of ways with a number of companies. I've been chief medical officer of 2 publicly traded companies. I've started companies. I've been on board of private and public companies. I've worked with investors, et cetera. So again, we came of the age in the 90s where, I was quoted in 1995 or 6 is saying electronic medical records will be ubiquitous within 5 years. Like a lot of things, these things never happen as quickly as you want, but eventually do happen. And so we grew up in this era of technology intersecting with healthcare, trying to improve efficiency, trying to improve quality, spending lots of money, seeing the government put money into this, seeing companies rise and fall, and a few survivors, like in many industries. So, over the years, I eventually left Northwestern at the end of 2017 and joined a company called MD Live, one of the big telehealth vendors. I was the number 2 exec there, helped them, expand, eventually sold for a couple $2 billion to Cigna, almost had an IPO. And now I founded another telehealth company that, one of the big hacks stories in healthcare, which you can't avoid, is Epic. I happen to be very aligned with Epic. I've started companies that work with Epic. I used Epic at Northwestern, rolled it out. And this latest telehealth company is the only telehealth company that works on Epic, with this philosophy of it's easier to go with the grain than against it. There's a recent published cartoon of sort of a ghostly figure, or a ghoulish figure of Epic, and all the AI companies, in the cemetery that it's killed. And people are very anti-Epic because if you're an investor and you invest in a company and Epic decides that they want to invest, create the same technology, your company may go under, just like Microsoft did in a lot of ways. But there are ways to work with Epic, and it's not going to be that drastic, but it is a huge influence on anyone in the healthcare industry. So my background, practicing physician, system executive, and then entrepreneur, starting both tech and services type companies.
Yeah. So, which is kind of where we intersected. So I was working for a small little tech,
small.
I don't know why I said that, pharmaceutical company called ICI Pharmaceuticals, which was the 19th largest pharma company in the world, which there was only 4 that mattered. So just think about how far down the list we were. That company became Zeneca. Now you know it as AstraZeneca. So worked there for a number of years. That's where I interacted with docs, got my feet wet in hospitals, ended up spending, I don't know, probably 10, 15 overnights in hospitals, spending time in burn units, spending time in probably saw 400 or 500 surgical procedures. So kind of caught the bug, then went into consulting, worked for a company called Baxter, which you guys know, some of you might know, big medical supply and device company for a number of years. And then in 2000, even though there was doctors like Lyle talking about electronic health records and medical records going mainstream, they hadn't happened yet. And so I joined a little small restartup company called Allscripts, which was a medication repackaging company that became a PBM, then back to a medication repackaging company. They came out with this thing where you can hold the device and magically send a prescription from the doctor's office to the pharmacy. 50-person company. I left Baxter, which is a 10,000-person company, the day my daughter was born, and took a 50% pay cut to see if I could learn tech from a great entrepreneur that some of you know, Glenn Tallman. So over the next 12 years, we helped mainstream electronic health records. I grew the company from 50 people to 5,000 people. Became one of the great stories of the time. Unfortunately, we finished a distant third to Epic. So it was good and bad and everything in between. Then I decided to take the lessons I had learned there. I joined a private equity-backed company called Strata. Most people, including me, hadn't heard of it. 50-person company, just like Allscripts had been. Had been around for 15 years, just like Allscripts had been. Needed to be restarted, just like Allscripts. And over the next decade, grew that company, sold it to a company called Roper Technologies, which some of you know, one of the largest publicly traded holding companies in the world. After 2 years, I stayed for another 8 years. Now 95% of U.S. healthcare runs on Strata, the company I was running, for operating budgeting, capital planning, long-range financial planning, rolling forecasting, cost accounting, all that kind of stuff. We had more data on the cost of care than any company on the planet. Tom Scanlon, sitting right over there, helped build something called Stratosphere, which was the largest repository of cost data in the world. Put machine learning on top of it. We're able to do real-time benchmarking and data normalization across 95% of hospitals eventually in the United States. About 8 months ago, I jumped on board with a private equity-backed company, TA, Susquehanna, Nordic Capital, 5 Arrows, which is Rothschild, are behind it, called RL Datix. RL Datix has the biggest footprint of patient safety, workforce management, and then data solutions of any company in the world, or at least one of the largest in terms of that zone. So as an example, in the UK today, probably 1.3 million nurses woke up and had to go to our app to figure out where they're going to go, when they need to be there, and what they're going to be doing. So we've got about 2,300 people on our team. We operate in 30 countries. And we have about 10,000 healthcare organizations globally on our platform. So that's kind of what brings us to now. So in terms of this space, this healthcare provider space, Lyle, one of the interesting topics is, in our time, Microsoft said that they were now in healthcare IT. Google had a huge effort. JP Morgan, Berkshire Hathaway, Amazon, Facebook, and they all failed to do it. What's your take on why that happened? And what's different about this space? What do investors need to know?
Everyone likes to think their space is special and different, but I really do think healthcare is. I taught a course for years at Northwestern to the second-year meds, which is called the Organization and Economics of Medicine. It's one of the course leaders. And it was interesting because these meds are super smart, right? Super ambitious. They knew nothing about how the healthcare system actually works. Like they didn't understand how insurance works, the difference between an HMO and commercial insurance, Medicare and Medicaid. They were completely naive. They could tell you the Krebs cycle, but they could not at all understand the financial and motivations. And we talked about that classic curve that shows that we, the U.S., spend more money than everyone else per capita, and yet our results are worse. And you look at things like
same chart that everybody shows.
Yeah, the same. And well, these guys may not see as much, but it's a horrible chart for us because we spend more, and yet our life expectancy and all these other factors are worse. So why is that? And then the other hand, there's no better place to get healthcare in the U.S. So it's a classic. We have great healthcare, it's just not equally distributed. Part of the issue, people will say, oh, it's because we have an employer-based health system or this or that, that we have, so many, that we don't have, just pure government-sponsored healthcare. But if you look across the world, there are places like Germany that's all employer-based insurance. There are places that have different types of insurance. The difference, I think the simple way to say it is everyone else has one main type of insurance, whereas we have so many different types that it's impossible to have a perfect system when you've got a government system, which, by the way, government pays for about half of all healthcare, covers about a third of the U.S. between Medicare, Medicaid, the VA, government, etc. They cover about 25-30% of all of the people in the U.S. and they spend about 50% because it's a tougher population. And then we have commercial insurance, and then you have HMOs and capitated versus fee for service. And so, how do you optimize for that system? You literally can't, because this patient over here, the more that they do, if they go to the ER, if they get surgery, the more you make as a health system. And this patient over here might be in a HMO, and you want to keep them out of the hospital. And so it's very hard. You have all these misaligned incentives. An article written by a futurist a couple of years ago compared it to, we've all probably, many of you have seen the movie The Beautiful Mind, Game Theory. You guys are all familiar with Game Theory, and that's healthcare. You've got to it's perfectly optimized for what it is and what it gets. And the problem is if you go in there and try and change it, this is why Dan is so smart, because he goes into companies that try and measure all this stuff rather than, and you probably change some of it by those metrics, but less on the clinical side, because the clinical side is what gets you. If you go in and tell a health system, I got great news, I can help you decrease the amount of ER visits. And you'd think, oh, well, that's a good idea. The health system's like, well, wait a minute, that's how we make money. I don't want, when I was the head of innovation at Northwestern, and companies would come to me and say, I've got this great product. Well, I'm going to ask you three things. Number one, who actually uses your product? Has to spend some amount of time. Number two, who pays for it? And number three, who benefits financially from it? Three simple questions, right? In most industries, you have a buyer and a buyer and a seller. Actually, Michael Lewis wrote a great book about this in the late 90s called The New Thing, and where it was Jim Clark.
Hey, Lyle, I get to talk to.
I know, I get to finish up. This is such a good thing. Jim Clark wanted to get in healthcare, and he said, it's just one more factor. You've got the patient, the provider, and the payer. But the problem is when you have three things, again, all of these problems become an issue when you're trying to find the right incentive alignment. So a lot of companies will say, hey, I'm going to give you this software, and you're going to pay for it. Your doctors will use it, and it will improve the quality of life for patients, decrease ER visits. The problem is the hospital is like, that's a lot of our expense, and the guy who benefits from it is the payer. It just doesn't make sense. So those aligned incentives are important. And then you have companies that actually help people figure this out.
Yeah. Well, the conundrum has been I'll do a little name drop because the name was mentioned in the first presentation. But I was at the big healthcare IT conference. It's called FHIMSS. There was 40,000 people there. We had a little booth right on your way to the bathroom. That was our strategy. You'd have to go by us on the way to the bathroom. So we were just 2001, 2002-ish. Maybe somewhere in that first 4 years of Allscripts. the second version of it. And William Blair was doing an investor tour, and they stopped at our booth, and Glenn Tolman's up there giving a presentation. And Corey Tobin comes over to me and he goes, "Hey, do you know who that guy in the North Face jacket is over there, sitting way over there?" And I'm like, "No idea who that is." He goes, "Sergey Brin." And I go, "Great. Who's that?" Like, I had no idea. And he goes, "Oh, the Go guy. Oh, yeah, I know that guy." And so then he brought him over and introduced us. And then me and this guy, Stu Shally, ended up giving a demo to Sergey for about an hour and a half. And he was asking all these great questions about healthcare. So about half an hour into this, I said to him, "Why are you so interested in healthcare?" And so I'll throw this quote at you. If you said, "All we've done well is search and advertising, and if that's all Google is, it'll be a complete waste of time." So I guess we were able to do things he wasn't able to. So they launched an effort. It didn't quite work out. And so the interesting part is now you have all these niche companies all around healthcare, whether you want to call Epic a niche company. If you want to go on the Acquired podcast, which many of you guys probably are familiar with, great storytelling of Epic. It's actually very accurate the way that they tell it. But, they've become the default option. They've become the standard. And in an industry that's, is risk averse, very much so. What happened, the phenomenon with Epic is really three things. One is they won the Kaiser deal. It was over $1 billion deal. It was on the cover of the Wall Street Journal. That's what gave it credibility, so people could point to that. Two, they had the highest customer ratings, Goddard. So it's called KLAS. KLAS is the industry default standard for that kind of work in healthcare, and they were number one in class. So that gave people the option. Or the next, and the last is that healthcare systems are complex. Northwestern over here has 60,000 employees. It's probably a $12 billion organization at this point, with roughly 400 to 500 different sites of care at this point in time. That's complicated. Imagine how many systems they have in applications. So the last thing was it was a single database solution. So it wasn't a very elegant solution. It was built on lumps. But that's what won the day, and then everybody followed. So momentum matters. Workday has now taken over the ERP space. Momentum started, Oracle and Infor basically leaving, or not leaving, being pushed out, I should say. This has happened over and over again. This company I was running, Strata, we had 0% market share. Now we have 95% market share. So what happens in this market is it's relationships and reputation, it's platforms, right? That's what happens. So when you're looking at it from an investor standpoint, the part that can be confusing is you can get dazzled with an AI solution and say, "Wow, that is amazing." And it makes so much logical sense, right? Problem is that they have no market presence, right? So one of the things that you mentioned to me, I forget the term you used, is that you guys are like a full stack AI solution or an end-to-end AI solution. I think some people may be familiar with that term, but can you explain what that means?
So there's so many AI tool companies right now, and that's certainly the hot thing everywhere, but in healthcare in particular, a lot of money going into that. And the issue is that when you're a technology company, of course, you need data, and you need some users. So when we started, saying, okay, well, we know since the beginning we're going to be a tech-forward company. We're selling tech-enabled services. We're going to be using AI. We'll buy, build, or partner on it. If we're building stuff, though, I think we read a term, it made sense that we are able to talk about ourselves as a full-stack AI company, meaning we've got, of course, the technology that we're building or buying, but we also have the data to train the technology, and we have users, we have physicians, and so we can quickly iterate and build. And the truth is, as you saw in the last presentation, building some of these tools is not necessarily the hardest part of it. It's a commodity. A couple of years ago, when the couple of companies came out with ambient AI, which is that technology, if you haven't seen it, the doctors will press a button and listen to the discussion you have, and it will create a note, right? That was magic 2 or 3 years ago, and you could charge $500 per doctor per month. Now there are 126 companies doing that, ranging from $200 down to free. Epic just announced they're rolling out their product, but the technology is becoming a bit of a commodity. And so having the ability to create the technology, the data, be able to use it internally, I think is a more powerful thing. And there's a couple of other stacks in there that become important.
But this ambient AI is that is the cat's meow right now in healthcare, right? So that's what everyone's getting excited about. It's saving doctors a significant amount of time. Like you were giving me the data on what you think doctor visit takes now versus what you think it will take in the future, or where it is today versus where it will go? You want to?
Yeah, well, so ambient AI there are three parts of the doctor visit. There's a pre-visit, there's the actual visit and post-visit. So during the visit now, the ability for this ambient AI to basically write the note for the doctor. It's interesting. It's found it's not actually saved a ton of time, but it's created much better notes for the doctor. The idea is, of course, these companies want to build on top of that and decision support and build. And unfortunately, of course, no surprise, the big takeaway might be better revenue cycle management and billing from that. We're also looking at what if you have the same type of tools talking to the patient ahead of time, gathering all the history, setting it up for the doctor. That's where I think we can save a lot of time, and post-visit doing some follow-up, et cetera. So we believe that particularly with the type of care that we do, online, routine type of care, we can really make the doctor more efficient, because we always talk about a shortage of doctors. I often say, we don't have a shortage of doctors as much as a shortage of using efficiently. And just like every other industry, we've got to figure out what we can automate, what we can delegate, so that we're not making new doctors. We've got to get our doctors more efficient, and AIs can be a big part of that.
Just to give people like a little bit of grounding, just talk about KeyCare, like how many employees, financial structure, all that kind of good stuff, just as people may be curious.
So the way we're set up, like most telehealth companies, is you've got KeyCare Inc. is the business. That's what, it's a for-profit business. KeyCare Medical Group is sort of the not-for-profit medical group who hires KeyCare Inc. to run it. That's how all these things are set up because of a variety of laws, et cetera. The idea is that we can go to a health system and say, we can be your partner because we use Epic also. We can connect our two instances of Epic. And we can be your overflow partner. We can help increase your access to patients, increase capacity, because the health systems, that's critical. The bigger number of patients they can touch, the more downstream revenue, whether that is in a fee-for-service or a capitated type of environment. Meanwhile, we're also now talking to payers and pharma. Anyone who needs a national medical group can come to us, and we are building up our doctors because we're on Epic. And because 60-70% of health systems now use Epic, we become part of the system in a coordinated way rather than in a transactional sort of off the books type of scenario. And because we can't create new doctors, we've got to make our doctors more and more efficient to be able to scale.
Yeah, and so in RL Datix, so we, the company over the last 5 or 6 years has acquired 21 companies. So it's that, that's the scenario. Now we're pulling it all into one platform for North America, very different healthcare system, very different needs in terms of the whole, and then one for the UK and international. So that's kind of our state of play in terms of how we're approaching things. And so I just want to give you a sense for companies like ours, which is a platform company, how we may look at a really cool AI solution that's sitting out there that, oh my God, they're doing this, we should be doing this, or we should buy that. Just really quickly. So we do a lot of staffing work. We already have an AI-powered tool that will do acuity forecasting so that you can do predictive staffing and optimize your staffing. So when you think of workforce shortage, which is an enormous issue in this country, much less in the NHS, much less in the UK overall, very big deal. So there's companies that just do that, and that's just a free tool that sits on top of what we do. We have, like I said, about 1.2 million medical professionals. They can go into our app, which is called Loop, and they can use an AI chatbot to kind of drive their decision-making on what shifts they do or don't want to take. We are the biggest patient safety platform on the planet. So we have more information, good information on bad things happening than any company in the world. So think of that when you talk about a full stack. How do we avoid harm in the future? That obviously can be informed about what has happened in the past. So you can then ask questions both globally and then locally in terms of improvements or changes or things that you want to change.
Did you get that information? Are you allowed to then use it to build your AI tools, et cetera? Do you have access to that?
We do for that purpose. Yeah. But Tom over here is working on, why don't you just tell them a little bit about, I know you've only been here 3 weeks. So Tom was the co-founder of my last company. It was a startup incubator to bring people together in the workforce called In Common. And then I convinced Tom to come over to RL Datix a couple weeks ago. But tell him a little bit about what you're working on.
Yeah, he also convinced me to come here 20 minutes before it started.
Yeah.
Right now.
Yeah. Well, because he is everything we're talking about with coding and everything we're talking about with the practical use of AI, that's the guy, right? So one of the more talented developers I've ever been around in my career, but he can actually get into all the minutia with you and build things in 24-hour cycles like people talk about. He's already doing that today. So anyways, not to over puff you, but
yeah. Well, yeah, so two of the projects I'm working on, one is a new interactive insights application for RL Datix. So on the UK side, they have all these hospitals, trusts who don't really know how they're doing compared to other hospitals and trusts right now. So we're building this very powerful interactive benchmarking solution, very similar to what we did at Stratosphere. And this is something that when I was at Strata, it took us a very full team, maybe 8-9 months just to get the MVP out in time for our October summit. Like Dan said, I started a few weeks ago, and because I'm using things like Cursor, P0.dev, et cetera, some of these different AI developer tools, I mean, we're about to start putting this thing in front of clients in 2 weeks. So
think of that, 9 months, ever many people, 2 weeks, one person, that gives you a sense for the reality of this. And the problem is a lot of companies like ours have a lot of data, but we don't know necessarily how to do and what to do with it and how to get that done quickly in rapid cycles. Because a lot of the developers, I'm sure, you see this all the time, are really good with the application that they built 10 or 15 years ago, but really can't make that leap into the things that they want to do today. So Tom and I talked a lot about this, but you can give these tools like Cursor to a mediocre or bad developer, and it won't help them absolutely not at all, right? That's the issue, right? It's the tool in the hands of somebody who knows what to do and how to do it, right?
Yeah, it's definitely exponential. The higher you get up to that curve, like better developers, how much better they get.
Yeah. Well, no, I just said one other thing. So like we have 500 or so people in product and dev across our company. We had an AI hackathon. We call it AI Rising 2 weeks ago globally. And we went against 47 use cases. Think about that. All 47 could be a company trying to build something on their own. 47 different use cases across our portfolio. And we were able to build these things in a week. At least the prototype, at least to get it to, are we going to move forward or not? And then the velocity with which we can build it is much greater because native coding is very difficult. Coding outside by extracting data and then just putting a chatbot on it, it's actually remarkably easy comparatively speaking. So really what you want from a lot of these products is insights, right, in action. And insights in action can be driven off the data, right, as opposed to the core code application. So when people say SaaS applications are going away, no, they won't. There'll still be systems of record. I mean, that's going to be a very important concept is what are those systems of record? And the systems of record already have the workflow. You're already in the hands of the user. So are you really going to want, I don't know, like when you use your iPhone or your Android device, if you go 3 or 4 or 5 or 6 pages deep in terms of your apps every day, that's great. But most of us just live off 1 or 2 apps for the most part. If you looked at our pie, it would be 90% of the time. And that might be our cue to take questions. I think that's what that is. And let me just do a time check because let's open it up. How much time do we have left?
10 minutes or so.
Okay, let's go. Yeah, David.
Dan, Lyle, thanks. I'm interested if you can touch on one of the area. When do you think AI/technology will sit in between or beside, is a better word, the patient and the doctor? Because it seems like doctors have to ingest just an incredible amount of data. They're managing lots of patients. This is a prime use case for technology to kind of sit, kind of beside the patient and the doctor and help guide care and empower patients with more information and doctors with better data. When does that happen?
Well, he's going to give the better answer, but let me give a quick answer. It's already happening today. So like when you do a search, right? Like something happened with a family member of mine the other day, right? And so we had to get some information on that. It was all the AI generated front end of that then linked us to Mayo Clinic that then gave us for diverticulitis, here are the foods you can or can't eat. No doctor interaction whatsoever. In fact, my mom, who's 84 years old, still wants to talk to a doctor because she wants to have that. But someone who's 24 years old wouldn't even think twice about that. I got the information. I'm good. I think there's a displacement here that's going on in healthcare that's extremely real. One. And number two, I would tell you, healthcare is risk averse, except when it comes to AI. Health systems are leaning in so aggressively to building their own solutions. It is remarkable. It will blow your mind. It's taken 12 or 15 years to mainstream SaaS and cloud-based solutions in healthcare because there was reluctance to do that. But now that flip is switched as of like 4 or 5 years ago. It took time. So you would give up.
And I think, and yes, certainly patients can go online and get a lot more, but they always could, in some way or fashion. It's just getting better. But I think what you're asking about is for the doctor, it's in there with the patient. There are multiple applications. First one is a summary. So it's going to give you a summary of all the past data, right? It's got your past electronic medical records. So a summary will come up, and then you as a doctor can make you can say, I want it short, I want it long, I want this summary focused on their cardiovascular or bias towards that. So those things are happening. So far, it's been iffy adoption just because most doctors is it really valuable to save me time? But like a lot of things, it's going to get better. Number two is decision support. There's always been if-then rules for decision support, but now we're starting to see more sophisticated levels, including some of the more interesting ones. Again, on the Epic side, just for the head of this, they have best care for your patient, which is where they'll show you. They have a database of hundreds of millions of patients. And they'll say, for this particular patient, this 51-year-old with hypertension on this drug, and it's not fully controlling the hypertension, here are the next best steps. And it's going to show you across 100 million patients. It's going to find similar patients and show you what actually happened when these different drugs were added. And this is the drug that is most likely to impact this patient. So we're seeing that level of support, which is pretty cool, as well as a couple of other levels of extra decision support. So it's starting to happen. It's going to, one, who's going to pay for it, right? Two, does it take extra time of the doctor versus save them time is the question. I think the more interesting things will be things that start replacing the doctor. Probably the most obvious ones are at a nurse level, things like preparing a patient for a colonoscopy. And we've seen now these AI, very telephone based. They'll call them up. They'll be a very pleasant sounding person, but it's all AI who will tell the patient, you're due for your colonoscopy. This is how you prep. Interactively answer questions.
I got one follow-up question. So Ryan called he's described in terms of how he's using AI to ingest all of his health data, all of his biomarkers, all of his history. When do you think that gets integrated with Epic, transparent, Verily, to give the patient, the doctor, this much more comprehensive view of their health today, their historical health, and what they should do?
It's starting to happen now. Patients certainly are dumping their data in. I was with some friends the other day. I showed them, Google, Apple and Google, right? Both have health apps that can pull in a ton of this data. And most people don't know about this. But I can pull in data from multiple EMRs, Quest, all of this stuff into one system. So I think we're getting closer to being able to.
Are either of those functional? Are they good programs, good apps?
Right now they're good for pulling in the data, and then they have open APIs to do that. So the nice thing is it can compare your lab, so you can look, and in one place you can pull up Apple Health, and you can see all of your visits, notes, prescriptions, vaccines, labs, tests, all in one place. Now, for a lot of people who go to just Northwestern, they're going to also get that through Epic's MyChart. Epic MyChart is starting to consolidate more. So you can, if I go to Northwestern, Rush, UFC, Mayo Clinic, I'll use Epic. I can pull it all in, so I can go into one Epic MyChart. I go to the Northwestern one and still see and pull in all the data from these other places as well. The Apple Health Kit and Google Health, whatever they're called, are able to take in that data plus things from Quest and maybe genomic data and other data and pull it all in as well.
Yeah.
So we're getting closer. I don't know if you've seen other ones that have done a better job.
No.
On the physician side, I found a company the other day called Abstractive Health, and I'm not sure how legal it is, but it seems to pull in data. I can put in a patient's name as long as I have a relationship with them. It will pull in data from a ton of different HIEs, which is health interoperability networks, and summarize it for me and make suggestions and let me basically do LLM type questions like, for this patient, should they be on what level of staffing should they be on? Should they be on an aspirin? So we're starting to see these come up. Again, the biggest problem is the business models. Who's going to pay for this? Some of the privacy issues, et cetera. But getting the data itself is not hard.
It's very similar to what Ryan was talking about, even though I hope this isn't being recorded because I don't want Ryan to test my bullshit meter, and see if I'm not telling the truth here. Think of finance, sports, and healthcare as being, wow, you got tons of discrete data, right? And then so you have objective kind of analysis, and then you have a lot of subjective analysis that goes with it as well, right? With healthcare, it's the biggest data industry there is and the biggest, part of the economy. So this is the thing that can really unleash this. So when Tom first showed me ChatGPT, if you remember that conversation, I was completely blown away because you can see it, you could feel it, it's going to have enormous impact on healthcare. In 1990, whatever, I felt the same way about healthcare. You just knew that all of healthcare is going to become automated. Well, guess what? Because all that automation happened, now you have the data and you could actually put this layer on top and you could do these things. So I think the next 20 years of healthcare, especially and maybe almost entirely because of AI, is going to be a massive opportunity. The only thing that I would say is don't be tempted by the shiny apple on this one. People understand healthcare as a consumer, but the reality is all healthcare money is spent really on the operations side. This thing that Lyle does, our applications aren't the clinical front end. They're not the financial back end. They're all the operations in the middle. And if you think of healthcare as an employer, it's a massive employer. It's the biggest employer next to the federal or state government or local government in every community, in every county of this country, right? So, and there's an enormous nursing shortage. People aren't like Lyle aren't going necessarily into medical school as much anymore, right? So this idea of how do you receive healthcare information, process things that are going on with you, and then take action from that. Well, we grew up meaning I had to talk to someone to be able to do those kind of things. The question is how necessary will that be? And the future is the right question. And then what are the implications on the back end, like hospital occupancy post-COVID? During COVID, hospital occupancy, whatever volume, which is what drives the economics of healthcare, went down, well, first 50%, then ultimately to 92%. Okay, so think of that. That's an 8% drop in volume. You may not think that's the biggest deal, but the average margin for a high-performing healthcare system is 5%. So there you go. You're already upside down. That volume has not come back. And then with Medicaid, what you've heard is real. The pressure on the top line from that COVID volume drop and the shift to outpatient, plus what's going on with Medicaid now, there's a financial crisis, which has always been talked about for multiple decades because it always is the case, but even more so now, that needs to be solved. The question is, how do you solve that problem? AI, when you hear about Tom and the velocity of a senior, extremely talented developer in the velocity it gave somebody who's a professional in that zone, think of the professional in this zone and what it could potentially do. It's stunning. Sorry. There was a question over here. Yeah, sorry.
One more thing that's important, just for everyone. In general, healthcare is not rocket science. You don't need AI. What you need is people actually, getting, some basic information and following. Eat better, exercise more, right? The real use of AI is going to be patient engagement in healthcare. It's not going to be there's no secret sauce. We're not hiding anything. It's not going to be like, oh my God, you've got to have this combination of vitamins to all of a sudden live longer. There's a lot of basic stuff that people aren't doing, and most people don't get engaged in their healthcare until they have a heart attack. Or this is going to be, a wealthy and healthy type room that's going to be more interesting.
How about two more? Sorry. Yeah.
I'll ask quick, just from an investor's perspective, there's a lot of people chasing this data, and developing tools very rapidly. Like, how do you pick the winners here, and who can create sustained advantage?
Oh, I'll go back to those three questions I mentioned. You got to understand, who's using the data, who's paying for it, who is benefiting from it, and how are those aligned? And if they can't answer that well, then you've got to make sure those things are aligned. One of the problems with patient-facing data is for the past decades, so many companies have tried to create, and that's what Google and others try. We're going to get all of your patient data and we're going to give it to the patient. The problem is there's no business model. And so, your investors, you need to make sure there's a clear business model and that everything's aligned correctly. And as simple as that sounds, it's extremely hard in healthcare because, as we mentioned, so many conflicting incentives. So that's why I'd say if they can answer those three questions well, it feels like a much better investment.
And I can add on to that, just building on what he said. The question is who is buying it, right? And what's their relationship to you? And healthcare is still a relationship business. So they're going to buy from people they know to a great extent. If you're selling into the healthcare system, right? Medical providers. If you're selling to insurers, that's a different market. If you're selling to patients, that's a different market. So there's a sub-segmentation and sub-segmentation that really goes on. And, the history of healthcare is niches. If you can really nail the niche, you can win. Then you can land and expand from there. Separate than that, it would be like if you're in 1999, this internet thing is coming, and you're like, well, which of these companies are going to win? You're going to have to, there's going to be a portfolio of winners and losers, I think, realistically. That's where the shiny apple thing really comes into play, because things actually are amazing. It's magical, like when you see what AI can do, and so that's very distracting to actually, well, hold on. How are you going to get to CFO? How are you going to get to chief safety officer or chief quality officer? How are you going to get to chief medical officer? How are you going to get to a CEO? Like everyone says, if you show it to a CEO, they'll be like, yeah, this is amazing. But very few people are ever going to get that opportunity to sell this thing to that person. So that's where platforms come into play. Like our strategy is, hey, we're going to be the operating system that sits in the middle. You got this clinical front end, you got this financial back end, a lot of these operational systems that have to do with the patient satisfaction, quality, safety, workforce management, credentialing, a lot of stuff that may seem kind of boring, credentialing, policies and procedures, audits and standards. Like a lot of the geeky stuff, the contrarian stuff ends up being really good markets in healthcare, right? It's not like, oh my God, that makes sense. And I'll ask my significant other what they think. And yeah. And I talked to one doctor and he said it was great. It doesn't fly that way. It's the contrarian play a lot of times. That's the most interesting. Like this whole AI scribe thing is a very good example of that because it is amazing to see the difference. A doctor, ambient listening is over here. Documentation's already done. So all the stuff I've dealt with for 20 years on electronic health records, that anxiety is no longer there. Amazing, right? 176 companies are doing it. And then Epic says, well, we're going to do it basically, essentially for free. How those companies doing? Well, it's not, do I have a good CEO? All the questions you would normally ask. What's the financial model look like? All the rational stuff. This is an emotional market to some extent, and people do go in waves. The waves come. You just got to find out what that wave is, where that momentum is, and where that niche is. That would be my perspective. And Goddard, maybe last question.
And my question, so you're building a platform, you have a lot of data, you're getting seconds. Are you more likely to build your own AI tools, or are you going to buy some of these startups?
No, I think that you're right. I mean, you would buy the startup almost like the Google would if we had that kind of financial structure just to get the talent, But as Tom will tell you, and Tom can give you the demystification of all these things, the data is where it begins, right? And the customer is where it ends. So if you got 10,000 customers and you've got the data, all you got to do is close that gap. So that's what I was talking about on our hackathon, that we had 47 different use cases that involve in individual companies that are building AI tools, right? So it's the talent is a problem, and the inertia of developers is a problem because it's difficult for other people to take to those solutions. And some of these legacy solutions like Epic, you're not going to go recode something off of bumps, but you don't have to be first. It's sort of like Apple. Apple is sometimes third or fourth or fifth, and sometimes they're 5 to 10 years late. Like they're coming out with a folding phone. Imagine that, right? But when Apple comes out with it, it will be a quality, it will be a market substance, it will be a brand, and so that becomes their, so just like any business, when you look at it, and you see so many, you have the greatest view of all the, more global view of more software companies than probably anybody on the planet. You might have a company sitting over here like Adobe. This new thing is so great, but Adobe could build it on top of what they're doing if they want to. And now they are. So everyone's getting religion.
I'll add an analogy to the internet. In 1998, 99, I was chief medical officer of a company called Proxicon, Internet Business Consulting. We were hired by Fortune 500 companies to build their internet sites, because they could do it. It's too fancy, etc. But what inevitably happened, of course, is they're like, wait a minute, it's getting easier and easier to do this, and we're just going to build it in-house. I think we are going to see that happen. I think there'll be structure. Epic has plans for about 120 AI tools that will become available as part of the product, but they're also coming out with an agentic AI platform to let the health systems start building their own agentic AI, because if you've been in healthcare, all health systems think that they know how to do it best themselves. They want to put in their special flavor, use their data, etc. So I do think it's a big risk for these independent companies. There'll be a couple winners, but there'll probably be platform plays that then allow you to build on top. And we're even starting to see one of the companies where they're creating a library where you, even as an individual doctor, could create some type of AI tool, and then a marketplace, you can sell it to others, whether or not someone will do it. But I do think that's going to be a big risk.
So we'll leave our contact information with Clint, but just wanted to thank Lyle. Appreciate it.
It was a conversation.